Welcome to Question Healthcare, investigative podcasting in ethics, health policy, and health humanities. I'm your host, Christy Rentmeester. Our guest on this episode is Devin Kellis. Devin is a student at the University of South Carolina School of Medicine, and he studies in a physician scientist training program. Devin is one of our exceptional junior colleagues in bioethics with a special interest in ethics and policy questions that surface where domestic and international health policies and practices intersect. You can learn more about his work at devinkellis.com. Welcome, Devin.
Thanks for having me.
So, Devin, you're with me in this episode to discuss a case that illuminates an understudied question in health policy and ethics. And that is, how should the obligations of healthcare as an enterprise change to manage the problem of single persons whose actions incur global excess morbidity and mortality? That is, excess illness, injury, and death. So that's the question that we're working with. Now, the power of rich persons to bring misery to persons who are poor is not a new problem. But what is fairly new is resource-rich individuals who rise to government positions because their power is supercharged by three key things. So number one, they do not need to be qualified or even seen as qualified to do the work that they are appointed to do in some cases. Number two, their moral agency, and thus their capacity to do harm, is outsized relative to their personhood. So their personhood is just like the personhood of the rest of us, but they can hit beyond their moral weight class, so to speak, because corporations they own now also have legal personhood. So some background here on number two. You'll recall the landmark decision in 2010 of the U.S. Supreme Court. The holding of Citizens United versus the Federal Election Commission maintains that the First Amendment to the U.S. Constitution protects corporations' election spending as free speech. So influential companies can speak way louder than the rest of us with things like campaign contributions. Now, number three. Such agents with this outsized capacity to do harm are no longer reined in by checks and balances on which we have typically relied to curb bad actors or poor judgment in government. The erosion of checks and balances in U.S. democratic processes has been a product of redistricting and gerrymandering, which is this third factor that compromises the potency of the U.S. electorate's use of voting to remove bad actors or poor decision makers from office. So we see each of these three factors give rise to a Department of Government efficiency that had morbid and mortal results for domestic and international health. In early 2025, the U.S. federal government reduced by over 80% the number of contracts it would support for the U.S. Agency for International Development, USAID. These funding restrictions generated stop work orders across the world, interrupting patient-clinician relationships and abruptly closing many long-standing sites of health service delivery and disease surveillance operations. Consequences of these closures include morbidly compromised access to food for the world's poorest children, increases in morbidity and mortality from numerous infectious, insect-borne, and other diseases. Consequences extended to many families, including to one child in Nigeria with sickle cell disease. And that is the case we consider in this episode. So this is a 7-year-old child in Nigeria who was sick with sickle cell. The child developed a fever. The child's parents took him to a clinic only to find that it had closed due to a stop work order from the U.S. federal government. The child's parent had no money for services from a hospital run by the Nigerian government. The 7-year-old child died. So, Devin, you have been thinking deeply about this case, and particularly about which short term and long term domestic and global health effects need our attention. So, are there health effects other than those that I've mentioned that you think need more attention in our considerations of this case?
Yes, there definitely are. And I think I would start by saying that the evidence for those health effects comes from a variety of different locations, from anecdotal reports by journalists and also by nonprofit organizations, and also by physicians in the field who have made observations, and also from modeling studies by academic researchers and individuals at nonprofit organizations. So the organization Impact Counter has estimated that in the year since USAID had its stop work orders, there's been more than 700,000 deaths from malaria, tuberculosis, diarrhea, malnutrition, HIV, and other diseases, with more than 500,000 of those deaths occurring in children. And in July of last year, there was a modeling study published in The Lancet suggesting that by 2030, up to 14 million people could die as a result of the cuts to USAID, with more than 4 million of those being children. And there was an even more recent modeling study published in a Lancet affiliate journal that suggested that at the severest levels of aid cuts, more than 20 million people could die by 2030. And in recent history, we've seen cuts not just by the United States, but by other Western nations. That has led some people to call the current situation the Great Aid Recession.
And Devin, you use a couple of analogies to help us think about why this Nigerian boy's compromised access to health services is an ethics problem that US based health policy folks should take seriously. Tell us about those analogies.
Yeah, so for example, you might imagine a stop work order being placed for specific procedures or techniques that are used in medicine. And one that I thought of because of its particular life saving capabilities is percutaneous coronary intervention, which is a method for treating heart attacks. And so you might imagine that if limits were placed on the ability to do this procedure at hospitals in the United States, the American public, which actually experiences a very high incidence of heart attacks, would be outraged to hear about this. So, as an example, the American Heart Association estimated in 2025 that approximately 605,000 new heart attack cases occur in the United States annually, and about 200,000 recurrent attacks. And so, if life saving interventions were suddenly eliminated, we would suddenly be faced with an influx of cardiovascular mortality. And so, that's one way that I like to think about this, to illustrate that just because these life saving interventions are being stopped in another country doesn't eliminate the fact that people are still dying. And it also seems very likely that the sorts of interventions that USAID was doing are much more cost effective than even percutaneous coronary intervention if you compare that to certain medical therapies for heart attacks. If USAID's interventions are actually much more cost effective, then the net harm to humanity is much greater than the cancellation, for example, of percutaneous coronary interventions by cardiologists in the United States. And that just serves to illustrate the magnitude of harm that can be caused by these sorts of orders.
You have pointed to this case of the Nigerian boy's death as one that illuminates ethics trouble with individuals who have, as I said before, this outsized capacity as federally authorized actors to harm persons who are poor. And you've been thinking about ways in which the organizations and individual persons in the health sector should respond. So tell us, Devin, which key areas of action that you and some other folks have been considering or implementing.
Yeah, there are a variety of different actions that people can take. But at the moment, at least to me as a medical student that's been following these issues, it's still very uncertain what the best actions to take are and what actions should be taken. I think that On the whole, the response to the end of USAID so far has been somewhat of a patchwork of different organizations and individuals stepping up to try to limit the damage. So, one example of ways that people have supported this patchwork response is through direct donations and charities. And so, just as there have been individuals with lots of money and power who have influenced the end of USAID, there have also been similar individuals that have made contributions to help ameliorate the harm being caused by the elimination of the agency. And so people have made massive donations in that regard to be distributed over the next decades. And there have also been new organizations that try to mimic the sort of interventions that USAID was performing. So there are organizations that, at a much smaller scale, are trying to replicate the sorts of services that USAID has been providing. Um, However, my understanding is that existing efforts to mitigate harm caused by the loss of USAID have not been fully effective in mitigating the consequences of the abrupt withdrawal of aid. Um, and most recently, um, one of the areas is the current Ebola outbreak, where there have been people that have reported uh, issues with personal protective equipment, as well as cessation of certain response teams, disaster response teams that have been eliminated since the end of USAID. And so I think we can say that, one way that people can help is through charity and nonprofits. Um, but it's unclear if that will be enough to make up for the loss of USAID. Another action that individuals can take is to support researchers and academics that study the effects of the end of USAID, and also to support other forms of investigation and journalism. And then lastly, people can vote for people who support the provision of health for both Americans and for people around the world, recognizing that we should vote for humanity in addition to our fellow Americans. We've seen a number of Democratic governors come together to form the Governors Public Health Alliance, which is being developed as a nonpartisan initiative, but at present does not have any Republican members. And so, one possibility is that, if you're not going this route of individual work and charity and nonprofits, that governmental agency below the national level in the United States can build connections with the global health ecosystem and try to have an influence in that manner. But it's not clear to me to what degree those efforts will lead to tangible benefits as compared to um, providing more tangible interventions. And I think ultimately it seems relatively clear to me that these sorts of interventions are very acute, and in the sense of, if you imagine like a trauma scenario of a patient coming into the emergency room with a trauma, these interventions are basically trying to just stop the bleeding that's happening, to stop the hemorrhaging that's happening acutely, um, without necessarily considering the downstream steps to prevent further harm in medical management. And so I think that ultimately there's going to need to be wider systems changes in the ways that these sorts of problems are managed, and also maybe systems put in place to prevent uh, the withdrawal of life saving aid in such a hectic and abrupt fashion.
So, a couple of the obligations that you might be suggesting here, Devin, is that the healthcare enterprise as a whole now has these additional obligations, one would argue, perhaps, to anticipate, regulate, and curb um, the federal strategies that are currently in place to maintain election spending as free speech, to continue erode the checks and balances that have made new demands that allow for the kind of outsized capacity to do harm that we're seeing in federal policymaking right now. And as a student, Devin, I think you have some particular authority here to speak on this as a matter of education. So, how do you think that health professions education should change to equip early career clinicians, your immediate peers right now, to think more powerfully about the nature and scope of domestic health policies' influences on national and international fellow humans who are poor?
I think that's a really interesting question. There's not really any major emphasis in many medical schools on the broader global health situation and looking into the epidemiology of disease outside of the country in which one is training. These sorts of things are considered to a much greater degree in public health programs, but not necessarily in medical schools. I think that the pre-medical education system should be reconsidered alongside the development of a new medical college admissions test, also known as the MCAT. The MCAT was last updated in 2015, and so when I first studied for the MCAT, I actually read a book by Kaplan that went over the history of the test, and it covered how, you know, back in the 1940s, um, specifically 1946, the test was called the Professional School Aptitude Test, and it had a section in it called Understanding Modern Society, which focused on issues outside of the scientific and even social science domains. And I think that bringing something like that back to medical training would be something that should be done. And the last thing I'll say is that going into the 21st century, we need to reconsider the idea of a resident as someone that's not just residing at the location where they're performing direct patient care, but also as members of a global community who have responsibilities not just to the people in front of them, but also people that are more distant from them. And this is actually keeping with the World Medical Association 2022 International Code of Medical Ethics, which says that medical professionals and doctors have responsibilities to global health and to larger societal structures and not just to individuals that are in their direct proximity.
Yeah, that notion of being a resident, staying at the hospital was in place to allow trainees to observe the etiology of disease. But one of the reasons that that was in place. But what you're pointing out here is that we don't necessarily need to observe those directly to be able to take them seriously and to have that be a ground for the moral obligations of a profession. Devin, thank you for being so thoughtful about this set of ideas. Thank you for being our guest.
Thank you for having me again. I enjoyed talking with you.
So, thank you to our guest, Devin Kellis, and thank you, our listeners, for being part of the Question Healthcare community. To learn more about QHC or to share a case or question that you might like us to investigate, go to healthpolicyethics.com. If you go to the Case Collective tab on the site, you'll find posts that summarize key ethics concepts and questions discussed in the QHC podcast. Thanks again.